I want you to remember a feeling. Not a recent one, probably. A morning when you woke up and the day felt like something to attack rather than something to survive. Your mind was clear before the coffee. Your body had a kind of quiet readiness to it, a physical confidence that did not need to be manufactured or maintained by stimulants. You wanted things. You pursued things. There was a groundedness to your energy that did not depend on what you had eaten, or how much you had slept, or whether your schedule was under control. That feeling has a name in biology. It is not simply high testosterone. It is a fully functioning androgenic system, the complete hormonal architecture of male vitality, operating the way it was designed to operate. And for most American men over 35, it has been diminishing so gradually that they stopped noticing it was leaving until the gap between who they are now and who they remember being became too wide to ignore. Stay with me through the next 20 minutes, because I am going to give you the most honest conversation about intermittent fasting and testosterone that exists in the health content space. Not the version that tells you fasting will automatically double your testosterone and transform your hormonal profile. Not the version that tells you fasting will crash your androgens and destroy your performance. The accurate version, the one that requires understanding the difference between a blood test number and a biological outcome, between total testosterone and androgenic function, and between what happens in the first 2 weeks of fasting and what happens after 3 months of consistent practice. The distinction between those things is the entire story, and most men never hear it explained with the precision it deserves. Let's start with the question you actually came here to answer. What does long-term intermittent fasting do to your testosterone? The honest answer, based on the current peer-reviewed literature, is it depends on who you are, and the blood test number is not the most important part of the answer. Let me explain exactly what that means, because it is not a dodge. It is the most useful thing I can tell you. The research on intermittent fasting and male testosterone is genuinely mixed, in ways that the popular health content on both sides, the fasting enthusiasts and the fasting skeptics, consistently fails to represent accurately. Several controlled trials, including a review published in the journal Nutrients, examining human trials on intermittent fasting and reproductive hormones, found that in lean, physically active young men, time-restricted eating protocols produced modest reductions in total testosterone. One controlled study found reductions of approximately 20% in total testosterone in young, lean male subjects following a 16-hour daily fasting protocol over several weeks. The researchers noted something important alongside this finding. Muscle mass and muscular strength were not negatively affected by these reductions. Physical performance metrics were preserved or improved. Body composition improved. The men were, by most objective measures of physical function, doing better, while their total testosterone reading was lower. That finding is not a contradiction. It is a window into something about male hormonal biology that most content never addresses: the difference between how much testosterone is circulating in your blood and how effectively your body is using that testosterone. And that difference, the gap between production and utilization, is where the real story of intermittent fasting and male hormone optimization actually lives. But before we get into the mechanism, let's be clear about the other side of the research picture, because it is also true that for men who are overweight or obese, men who are carrying significant excess body fat, who have established insulin resistance, and who are not lean young athletes, the intermittent fasting and testosterone story looks meaningfully different. For this population, which describes a very large percentage of American men over 40, the metabolic improvements that intermittent fasting produces, improved insulin sensitivity, reduced visceral fat, lower systemic inflammation, create the conditions for indirect but genuine improvements in androgenic function. A 2024 review examining the impact of weight loss on testosterone levels found consistent evidence that reductions in excess body fat, particularly visceral abdominal fat, are associated with improvements in testosterone levels and hormonal profiles in men with obesity. Not dramatic improvements, but real, meaningful, mechanistically explained improvements that operate through pathways we are going to cover in detail. So the complete honest picture is this. Intermittent fasting in lean young men may modestly reduce total testosterone while preserving or improving physical performance and body composition. Intermittent fasting in overweight men may improve the hormonal environment indirectly by addressing the metabolic conditions that were suppressing androgenic function. And for both populations, the total testosterone number on a blood test tells you considerably less about how you actually feel, perform, and function than the broader picture of androgen receptor sensitivity, insulin environment, visceral fat load, and the inflammatory backdrop against which testosterone is operating. Let me build that picture for you, mechanism by mechanism. The first mechanism is the one that most men practicing intermittent fasting actually experience without having a biological explanation for it. Around weeks 3 to 6 of consistent 16 to 8 fasting, after the initial adaptation period is complete and the metabolic machinery has shifted, men commonly report something that does not match what a lower total testosterone number should theoretically produce. More mental clarity, more stable energy, a return of competitive drive that felt absent. Sometimes an improvement in libido that the early weeks of fasting had suppressed. They feel more like themselves hormonally, even if their blood test shows a number that a physician might classify as unchanged or slightly reduced. The explanation for this experience lives in androgen receptor sensitivity, the responsiveness of the cellular docking stations that testosterone must bind to in order to exert its biological effects. Testosterone does not produce its effects simply by circulating in your blood. It produces its effects by binding to androgen receptors embedded in muscle tissue, brain tissue, bone, and other organs. When testosterone binds to an androgen receptor, the receptor hormone complex enters the cell nucleus and activates gene expression that produces the downstream effects you experience as testosterone's action. Muscle protein synthesis, competitive motivation, sexual drive, cognitive sharpness, energy regulation. Here is where chronic insulin elevation creates a problem that goes beyond blood glucose management. Chronically elevated insulin, the state that most American men maintain for most of their waking hours by eating across a 12 to 15-hour daily window, appears to reduce androgen receptor sensitivity over time. The cellular receptors that testosterone needs to bind to become less responsive, less willing to activate. The signal-to-response ratio drops. Your total testosterone might read 400 on a lab panel, and your body might be responding to it as if it were 300 because the receivers are dampened. Fasting, by creating consistent windows of genuinely low insulin, appears to restore androgen receptor sensitivity. The same amount of testosterone produces more biological effect because the receivers are functioning more responsively. You get more signal from the same broadcast. This is the mechanism behind the paradox that multiple researchers have noted. Intermittent fasting studies in men sometimes show modest reductions in total testosterone alongside preserved or improved physical performance, muscle mass, body composition, and subjective reports of energy and drive. The number went down. The function went up. Because function is not the number. Function is the interaction between the hormone and the receptor. And that interaction depends critically on the insulin environment in which it is occurring. A practical analogy that makes this concrete. Imagine your testosterone production as a sound system's amplifier. Androgen receptors are the speakers. Total testosterone is the amplifier's wattage. But if your speakers are blown, If chronic insulin elevation has degraded the components that are supposed to convert the electrical signal into sound, you can have a powerful amplifier producing noise that nobody in the room can hear clearly. Fasting does not necessarily increase the amplifier's wattage. What it does is repair the speakers so that the signal that is already being produced actually gets heard. Now let's address the mechanism that most directly separates the hormonal outcomes of men who are lean from men who are carrying significant excess body fat. Because this is where the two populations diverge in ways that have practical implications for what you should expect from a fasting protocol, depending on where you are starting. Visceral adipose tissue, the fat packed inside your abdominal cavity, surrounding your liver, pancreas, and other organs, is metabolically active in a way that directly and adversely affects the testosterone to estrogen ratio in men. Visceral fat contains high levels of aromatase, an enzyme that converts testosterone into estradiol. The more visceral fat a man carries, the more of his testosterone is continuously being converted into estrogen, rather than remaining available for androgenic signaling. This aromatization process is one of the primary physiological mechanisms underlying the hormonal symptoms that overweight middle-aged American men commonly experience. Declining drive and motivation, reduced muscle mass despite adequate protein intake, increased moodiness and emotional reactivity, accumulation of fat around the chest and midsection, and reduced libido, all of which reflect not simply low total testosterone, but an unfavorable testosterone to estrogen ratio driven by excess visceral fat converting testosterone to estradiol. Intermittent fasting, as we have established in previous discussions, produces preferential visceral fat reduction. The hormonal environment of extended fasting, low insulin, elevated norepinephrine, elevated growth hormone, specifically and disproportionately mobilizes visceral adipose tissue compared to subcutaneous fat. As visceral fat decreases, aromatase activity decreases. Less testosterone is being converted to estrogen. The hormonal ratio shifts in a favorable direction, even if total testosterone production has not meaningfully changed. This is the mechanism through which men who lose significant visceral fat through intermittent fasting often report hormonal improvements that their lab panels partially, but not fully capture. The testosterone number may not change dramatically, but the ratio of testosterone to estradiol improves, and it is the ratio that governs most of the biological experience of androgenic function in men. The third mechanism involves the direct relationship between insulin resistance and testosterone production at the level of the testes and the hypothalamic pituitary gonadal axis. Insulin resistance, the state where your cells require progressively more insulin to produce the same glucose-clearing effect, is now well understood to be a suppressor of testosterone production through multiple pathways. Elevated insulin chronically suppresses luteinizing hormone pulse frequency from the pituitary. Luteinizing hormone is the signal that tells the Leydig cells in the testes to produce testosterone. Less LH pulsatility means less testicular testosterone production. Additionally, insulin resistance is associated with elevated systemic inflammation, and chronic, low-grade systemic inflammation independently suppresses Leydig cell function. The testes are genuinely less productive when the body is operating in a chronically insulin-resistant, inflamed state. Intermittent fasting is one of the most evidence-supported dietary interventions for improving insulin sensitivity. The consistent creation of extended low insulin windows through daily fasting directly improves cellular insulin sensitivity over weeks and months of practice. As insulin sensitivity improves, the chronic suppression of LH pulsatility from insulin excess is reduced. As systemic inflammation decreases in response to the gut, rest, and reduced inflammatory load that fasting produces, the inflammatory suppression of Leydig cell function is partially relieved. These mechanisms operate over longer timeframes than a few weeks. They are part of the 3 to 6 month story of what consistent fasting does to the hormonal environment, and they are the reason that men who persist with the practice past the early adaptation phase often see outcomes that the first month blood test does not predict. The eating window timing matters more for hormonal outcomes than most fasting content acknowledges. Testosterone production follows a diurnal rhythm, with peak production occurring in the early morning hours and declining across the day. The largest testosterone pulse of the day occurs during the last phase of REM sleep in the early morning. Maintaining a fasting window that does not overlap with the primary sleeping hours, which 16 to 8 with a noon to 8 eating window does not, ensures that the overnight growth hormone and testosterone production cycles are not disrupted by late eating. Eating until 10 or 11 at night compresses the overnight fasting window and reduces the growth hormone release that occurs during the early hours of sleep, when growth hormone pulsatility is highest and most critical for both muscle preservation and androgenic support. Protein adequacy within the eating window is non-negotiable for men specifically, because testosterone's anabolic effects on muscle tissue are protein-dependent. The hormonal signal requires adequate substrate to produce its intended outcome. A daily protein target of approximately 1 gram per pound of body weight, distributed across 2 or 3 deliberate meals within the eating window, provides both the substrate for muscle protein synthesis that testosterone is trying to drive and the satiety signaling that prevents overeating patterns that can counteract the hormonal benefits of the fasting period. Prioritize high-quality animal proteins, eggs, red meat, poultry, fatty fish, which provide not only complete amino acid profiles, but also the dietary fat and micronutrient content that support steroidogenesis. Testosterone is synthesized from cholesterol. Dietary fat from quantity animal sources provides both the cholesterol substrate and the fat-soluble vitamins, particularly zinc and vitamin D, that are directly required for testosterone production. Men eating very low-fat diets during their eating windows have consistently shown lower testosterone in research compared to those eating moderate to higher dietary fat. And this is a practically relevant consideration for men using fasting specifically as a hormonal optimization tool. Resistance training timing relative to the fasting window deserves specific attention for men concerned about optimizing the growth hormone and testosterone response to exercise. Training in the fasted state, during the latter hours of the fasting window, before the eating window opens, produces a different hormonal environment than training in the fed state. Fasted training elevates growth hormone more dramatically than fed training, enhances fat oxidation during the session, and appears to improve insulin sensitivity more robustly in some research. The practical concern about fasted training, that it will produce muscle catabolism, is addressed by the growth hormone surge we have already discussed, and by breaking the fast with a protein-rich meal immediately after the session, which provides the amino acid substrate for muscle protein synthesis exactly when the post-exercise anabolic window is most responsive. This combination, fasted training followed by a protein-rich first meal, is among the most effective practical implementations of the hormonal optimization rationale for intermittent fasting in men. For men over 40 specifically, the protocol should include regular lab monitoring rather than relying exclusively on subjective experience. A comprehensive hormonal panel every 6 to 12 months, total testosterone, free testosterone, SHBG, estradiol, LH, FSH, prolactin, and DHEAS, alongside standard metabolic markers, provides the objective data needed to assess whether the fasting practice is producing favorable hormonal outcomes for your specific biology, or whether adjustments are needed. Some men find that extending the fasting window beyond 16 hours produces hormonal improvements. Others find that 16 hours is optimal, and longer windows begin to elevate cortisol into the range that suppresses the HPG axis. Individual variation is real and significant, and the only way to navigate it responsibly is with actual measurement rather than assumption. Let's be direct about the one situation where intermittent fasting, as described in this video, is contraindicated for men specifically concerned about testosterone. If your total testosterone is already clinically low, below 300 nanograms per deciliter with symptomatic presentation, fasting is not the primary intervention. The hormonal deficit at that level requires clinical evaluation of the HPG axis, thyroid function, sleep apnea assessment, and potentially consideration of testosterone replacement therapy in consultation with a physician. Fasting can be a useful complementary tool in that context, improving insulin sensitivity, reducing visceral fat, supporting the conditions for better endogenous testosterone function. But it is not an alternative to addressing clinically significant hypogonadism through appropriate medical channels. The distinctions in this video apply to men in the normal to suboptimal range who are looking to optimize a functional hormonal system, not to men with clinical hormonal pathology.